Hello, my name's Linda Stotchel. My presentation is on back pain and neuromuscular injury and problems. And we're going to start with the back pain today and then go on into a lumbar disc syndrome, which includes the herniation and degenerative changes, as well as whiplash, some cervical sprain or strain, and shoulder pain. There are all types of back pain, and a couple of the types are listed here. The local, where that's just near where it has been injured. Referred pain, that may come from the abdominal or pelvic viscera. A pain from the origin of the spine that could be referred to the back or the butt or the legs. You can have muscle spasms and radicular back pain. When you're checking the history for someone that is coming in complaining of back pain, a couple of things that you need to find out. Is the pain worse at one time more so than others? Do they have a prior history of cancer? Do they have any type of chronic infections like the lung, urinary tract, or skin? Do they have a history of trauma? Incontinence, greater than 50 years old, an IV drug user, a glucocorticoid use, or some type of progressive neurologic deficit. There are alarming back pain signs and symptoms to be aware of, and this is such as unexplained weight loss, failure to improve with the treatment, severe pain for more than 6 weeks and night or rest pain. It's very difficult to find the cause of the back pain, and these are just a few of the causes, whereas it can be congenital, developmental, minor trauma, fractures, trauma fractures, intervertebral disc herniation, or some type of other cause. When you're looking at pain, there's a wide range of symptoms. Your duration, less than 6 weeks is acute, greater than 6 weeks is subacute, and less than 3 months. But chronic is longer than 3 months. And the cause is usually not found, and a lot of times it will resolve in 4 to 6 weeks. But the primary goal of the care is to provide and encourage care and activity, but educate the patients about the symptoms that should cause alarm and prompt a return visit to the patient physician. Low back pain has a prevalence of having 80%. The male-female is equal as far as having back pain. The bimodal distribution with age is the first peak of people with low back pain will usually be somewhere between 25 and 29 years old, and the second peak is after 65 years old for women and older for men. The risk factors are increasing age, activities such as lifting, bending, twisting, obesity, having a sedentary lifestyle, physically strenuous work, psychosocial factors like anxiety, depression, and stress, and smoking. To help prevent having back pain, maintain a normal weight, physical fitness and activity, stress reduction, proper lifting technique, good posture, and smoking cessation. We've talked about the red flags when you're taking your history, but also you want to look at the onset of pain. Is it sudden or gradual? And look at how is it provoked with motion, the flexion, extension, side bending, rotation, sitting, standing, lifting, any of that. Is it relieved with rest? Radicular pain may radiate into the buttocks, thighs, and upper back, and the patient may note improvement with NSAID use. When you're examining someone with a back injury, very thorough physical exam is necessary. Observe how the patient is walking, look at how they're laying on the table, the facial expressions. The lumbar spine range of motion you see there with the flexion, extension, side bending, and rotation. When you palpate, do you hit points of tenderness? Do they have muscle spasms? The neurologic exam consists of visual, and of course you want to test their lower extremity reflexes, strength, pulses, sensations, and do a straight leg test. The differential diagnosis depends. If are you looking at a musculoskeletal type problem, inflammatory, infectious, neoplastic, or referred pain. Your diagnostics, no lab if it's the initial contact usually, and there's no red flags. If you suspect a malignancy, a ESR, serum alkaline phosphatase, and CBC. And if it's a neurologic deficit that's present, you can suspect called equinina syndrome, and do a surgical consult. The treatment of low back pain is reassurance that the pain is usually self-limiting, and their first line of therapy is encourage activity if you're tolerated, and specifically back mobilizing exercises. Medications like the NSAIDs with the ibuprofen, naproxen, aspirin, acetaminophen. If they're really moderate to severe pain, you may look at your Flexerils, your hydrocodone, your methadone, and then alternate methods there is through the epidural and the Botox. You're looking at a lumbar facet joint intervention. There is good evidence for the use of this radio frequency, and the nerve blocks for treatment of chronic lumbar facet joint pain. With the low back pain, you always want to have follow-up and see how the patient's doing. Are they maintaining their exercise program, and continue education and patient monitoring is needed. Have them follow up 2 to 4 weeks after the initial presentation to monitor their progress and assess the severity and quality of pain and range of motion. And if they do not have improvement, then it's time to reevaluate. This is an algorithm for acute back pain. If you look at the bottom there, you can see the differential diagnoses like we were talking about earlier. And then the next slide, let me get to that. This slide is on low back pain acute, and it's a little bit different because it's a little bit more specific than just the regular back pain. This section's going into neuromuscular problems, and this is a lumbar disc syndrome, and this is going to include the herniation or degenerative changes. And as we spoke just a minute earlier about the protruding disc that may called a equina syndrome. The clinical findings for the lumbar disc syndrome may include mild herniation without nerve root compression, herniation with nerve root compression called equina syndrome, chronic degenerative disease with or without symptoms, spinal stenosis, low back pain that worsens with activity, coughing, or sneezing, local lumbar or lumbosacral tenderness, paresthesia, and that's usually interlateral, decreased low back motion, increased pain on bending toward the affected side, weakness and reflex changes, lumbar stenosis, as well as a positive straight leg raising test if the nerve root compression is present. The prevalence of finding this syndrome is 1 episode in about 80% of adults. Male and female are equal. Herniation usually occurs in 20 to 40-year-olds. Stenosis is greater than 40 to 50-year-old, and distant symptoms are rare, and it's less than 20 years old. Differential diagnoses, it could be soft tissue strain or sprain, tumor, degenerative arthritis of the hip, or insufficiency fracture of the hip or pelvis. The workup for the lumbar disc syndrome, the diagnosis may be established on a clinical basis alone. Imaging is not warranted initially for most patients, and there are some electrodiagnostic studies that may confirm the diagnosis or rule out peripheral nerve disorders. The treatment course is a short 3 to 5 days of limited physical activity for acute disc herniation with leg pain. Physical therapy modalities, you gradually exercise, lumbar corset, percutaneous electrical nerve stimulation may help some patients. The medications are an NSAID, muscle relaxant, analgesic. You may have some injection for the back that has some limited benefit. The disposition is almost all lumbar disc syndromes improve with time. Recurrent episodes usually respond to the medical management, and recovery, though, from a rare paralytic event is often incomplete. The red flags suggesting a more serious condition as a cause of back pain may include fever, the history of malignancy, pain at rest, incontinence, sudden worsening in the level of pain, weight loss, significant motor loss, especially if associated with saddle anesthesia. And as any of things that are these may be noted, you may need to refer to an orthopedic or neurosurgeon consultation for intractable pain or significant neurological deficit, and emergency referral for cauda equina syndrome. This section is neuromuscular injuries or problems related to a cervical muscle sprain, strain, or spasm. The epidemiology shows that men and women are equal in regards to these cervical problems. They usually last about 2 weeks or longer. They occur in about 8% of persons 25 to 74 years of age, and they are highest in the age group of 45 to 64. They're higher in whites than blacks or any other racial group. 85% occur as a result of an MVA. 60% improve the first year, 32% improve the second year, and 8% have permanent problems. One of the cervical muscle sprain, strain, or spasms is a whiplash. This is an acceleration, deceleration of the neck with a rapid flexion extension is a common event of motor vehicle accident. Whiplash occurs when you're involved in a motor vehicle accident and you're rear-ended by another vehicle. The pain is not present possibly until 12 to 14 hours later to a few days. Neck tightness, stiffness, occipital headache, shoulder, arm, and back pain, numbness in the arms, tinnitus, a TMJ pain, dysphagia, decreased range of motion, depressive symptoms. Now, if this was a really hard hit, then the symptoms may be present within 12 to 14 hours. The etiology is the injury is the result of a sudden acceleration of the body forward, forcing the neck to hyperextend backwards, causing injury to the ligaments, muscles, bones, and or intervertebral disc. And at the end of the accident, the head is thrust forward in a flexion position, sometimes causing injury to the cervical spine, C5, 6, or 7. Motor vehicle accidents, trauma from falls, contact sports, physical abuse, and altercations are all possible causes of whiplash. One of the things with whiplash is you need assurance. Support the neck with a soft cervical collar, but usually it's no longer than 48 to 72 hours, but they do encourage using it at night. Moist heat compresses 15 to 20 minutes, 4 to 6 times per day. Control physical activity and your PT modalities. Pharmacy is ibuprofen, naproxen, acetaminophen. Your muscle relaxants are your Flexeril, Robaxin, and Somas. Usually no lab. Imaging studies is a plain C-spine film, and that includes anterior, posterior, lateral, and odontoid views. Flexion extension x-rays. If further investigation is needed, then a CT scan to exclude a fracture, and the MRI is an alternative. Differential diagnoses are osteoarthritis, cervical disc disease, migraine headache, neuritis, TMJ, and that's all. Trauma to the cervical spine may result in major neural damage with paralysis, and if history reveals significant trauma, then due to significant consequences of the potential damage to the spinal cord, referral to an orthopedic surgeon or neurosurgeon should be made. This is a picture of the contra-coot head injury for whiplash, where your head goes backwards and it goes forward, and you can tell the brain is getting hit on the back and the front inside the skull. Other cervical muscle sprain, strain, and spasms. Cervical sprain is pain in the neck area associated with a concomitant loss of neck motion and stiffness. Is rarely identified. The cause is rarely identified. Cervical strain results in elongation of the muscle fibers with subsequent edema to rupture of the muscle tissue and secondary hemorrhage. Muscle strain and ligament sprain. And a spasm is increased muscle tone that is shown by rigidity and spasticity. The next section is shoulder pain. The risk of having some type of shoulder pain is when you have repetitive overhead activities, when you do a lot of weight-bearing sports, baseball, softball, swimming, weightlifting. You have rapid increases in training frequency, may not be doing proper technique, muscle weakness or imbalance, trauma or fall onto the shoulder, and then diabetes, thyroid disorders, and female gender, age 40 to 60, are risk factors for adhesive capsulitis. This affects all ages. Less than 30 years old is shoulder instability. Greater than 30 years old is rotator cuff disorder. 30 to 50 is tendinomyopathy. 40 to 60 is a partial tear. Greater than 60 is a full thickness tear. And also osteoarthritis of the glenohumeral joint. Causes may be trauma, overuse, age-related, rheumatic, and referred. The differential diagnosis for shoulder pain could be a fracture, a rotator cuff disorder, a subacromial bursitis, and adhesive capsulitis. Diagnostics, most of the time, is by history and physical. However, trauma, prolonged symptoms, or red flags of age, fever, or rest pain may indicate further studies to be needed. The MRI is a gold standard for non-invasive imaging of soft tissue structures, and this includes the rotator cuff, bicep tendon. The treatment of shoulder pain is based on the underlying pathology. Conservative treatment is what's recommended, and that's rest, analgesics, or anti-inflammatory medications. They may be required for the symptomatic relief of the pain, and you should refer when shoulder pain etiology remains unclear or that it is unresponsive to a conservative care, and it could be complicated or displaced fractures with large rotator cuff tears. All those should be referred. Physical therapy may provide benefit if it's unimproved with conservative measures, but consider rotator cuff disorders, adhesive capsulitis, or shoulder instability. Manual manipulation therapy may be required, but that's done by other medical professions, and surgery may be necessary for shoulder pain caused by acute displaced fractures, a large rotator cuff tear, shoulder dislocation in patients less than 20 years old. And so surgery is also necessary for shoulder pain unresponsive to conservative measures greater than 3 to 6 months. Acupuncture may help, but there's no conclusive evidence of this.